From Microbe TV, this is Infectious Disease Puscast episode 77, recorded on Thursday, March 27, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I don't have much banter. I feel like it's been a pretty tough couple weeks for folks.
It has been. I think the reason Vincent has me do these, I think like he gets paid off by my family and friends, because otherwise, like if I don't have this outlet to vent and discuss the exciting medical literature and developments, like my family has to hear it all. But I gotta say, things are tough in infectious disease, and particularly at Columbia, right? So. A lot of people, if your grants had any of those buzzwords like vaccine or virology or infectious disease or mRNA or, you basically got a letter saying your funding has been canceled. They shut down the Office of Long COVID at the NIH. So, it's tough time. And really, probably the most disturbing to me, Sara, is that the peddlers of misinformation have succeeded in misinforming people to the point where they're making bad decisions, and we have children getting hurt, children ending up in the hospital. It's not good.
Yeah, it's a little hard to fathom the numbers of people and things that are being sort of ripped apart each day. Anywho, okay. Well, let's talk about some things that we.
No. All our listeners have tuned off. They're like, I'm depressed. But here,
sorry,
here is hang in there. This is a bright spot.
But people I think you also. It helps to talk to other people that also feel the same way and feel down. But we're gonna highlight some things because ID is awesome. So Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So how about we talk about some literature?
All right. Well, let's start off with viral, and we do have some great stuff this time. Remember to listen to TWIB, This Week in Virology. The way the timing comes out, the deep dive and my clinical update, which will already be recorded, and then this comes out afterwards. So keep listening to those. Got some exciting measly discussions going on there. But let's start off with the article, Food is Medicine for Human Immunodeficiency Virus, Improved Health and Hospitalizations in the Changing Health Through Food Support, Chef's HIV Pragmatic Randomized Trial, published in JID.
Excellent.
How did you not go chefs?
I know, it's excellent.
That's
well, you
right
know me, I'm always looking for reasons to combine food and ID, which most people don't want you to combine, but extra.
So for background, they tell us that no randomized trials have heretofore investigated the benefits of medically tailored food programs for people with human immunodeficiency virus. The Chef's HIV, Changing Health Through Food Support, that's where they get chefs, pragmatic randomized trial included people with HIV who are clients of Project Open Hand, POH, a San Francisco-based nonprofit food organization. The intervention arm received comprehensive medically tailored meals, groceries, and nutrition education. Control participants received less intensive, so just standard of care food services. Health, nutrition, and behavioral outcomes assessed at baseline and 6 months later. Primary outcomes were viral non-suppression and health-related quality of life. Now, what did they find? Doesn't this seem like a niche, right? I'm going to start making menus and then following health outcomes. So they found the interventional arm had lower odds of hospitalization, odds ratio 0.11. So almost a 90% reduction in hospitalization over 6 months.
Awesome.
It's amazing, right? So
yeah, it's really great.
they also saw a 68% reduction in depressive symptoms, odds ratio 0.32. People getting the chef's intervention had a greater than 80% reduction in failing to take their antiretroviral therapy over 90% of the time. They saw less people having unprotected sex. Do you believe that? If you eat really good food, you're less likely to have unprotected sex. And that was a 82% reduction over 6 months compared to the control arm. But the interesting thing is there was no difference between the study arms in viral non-suppression and health-related quality of life over 6 months. Now, I found this a little too impressive, right? So I'm going to start digging in. So I looked further into this POH, this Project Open Hand, founded in 1985, currently provides free medically tailored food support and nutrition counseling to over 1,000 people with HIV in San Francisco and Alameda counties. Significant funding from the Ryan White HIV/AIDS Care Act. Hopefully they're going to keep getting that. The POH, Project Open Hand facilities, include space for meal preparation, storage, distribution. They've got a grocery center where clients can select healthy foods. Through this program, people living with HIV receive either one meal equivalent, level 1, or 2 MEs daily, level 2, through groceries or prepared meals. Now, what's on the menu? The food selection was informed by carbohydrate guidelines from the American Diabetes Association and saturated fat and sodium guidelines from the American Heart Association, with individual tailored for calories and specialized diets. So you get mechanical soft, you can get vegetarian. The food plan varied each week, low in refined sugars and saturated fats, featured fresh fruits and vegetables, lean proteins, healthy fats such as olive oil, whole grains, all consistent with the DASH and Mediterranean diets. A supplemental bag of groceries. You get a little extra olive oil, herbs, spices, soups, grains, beans. In this study, there were 11 fewer hospitalizations in the intervention arm than in the control arm over 6 months. And they do this analysis. So given a daily cost of $3,535 for hospitalization and mean length of stay at 4.6 days, in California, this intervention could have reduced hospitalization costs by $178,781 just among the study participants. Now, I kind of wanted to see the other side. Well, how much did this cost, right? Because we have about 200 people in this intervention, so you're reducing it. I guess you can sort of calculate it in your head. How much money are you saving per participant? How much does that cost? And they have a really nice chef's HIV intervention, graphical abstract, which looks nice. But yeah, really impressive, right? I mean, maybe this is a silver lining, right? There's a lot of discussion about we focus too much on the pharmaceutical, and maybe we need to focus more on the whole person. And this was a really nice study showing that you can have some really great bang for your buck with this diet intervention. All right. I see you nodding along. So, podcasters, Sarah's nodding along.
Sorry.
No, that's...
No, it's lovely. What a great way for us to contrast the way we opened the episode. So
right. This is 90% reduction in hospitalization. Yeah. Less people have an unprotected sex because they feel better. They feel more valuable. They want to take care of themselves. And this is great stuff.
Yeah.
All right.
Really cool.
Now, the article, The Epidemiology and Burden of Human Parainfluenza Virus Hospitalization in U.S. Children, published in JPIDS. So in order to quantify the burden of parainfluenza hospitalization to evaluate the characteristics of children hospitalized with PIV by virus type, these investigators used data from the new Vaccine Surveillance Network, a multi-center, active, prospective, population-based surveillance network, enrolled children hospitalized for ARIs, acute respiratory illness, defined as fever and or respiratory symptoms at 7 U.S. children's hospitals. The study period went from December 1, 2016 through March 31, 2020. Data captured included demographic characteristics, clinical presentation, underlying medical conditions, discharge diagnoses, and viral detection by RT-PCR of 16,791 enrolled children with PIV virological testing. 10,488 had only one respiratory virus. You kind of do the math. About a third of them had co-infections, right? Among whom 7% had positive testing for parainfluenza virus without a co-detected virus. Of these 702 children, 48% had an underlying comorbidity. So that means over half, 52%, had no comorbidities. They get parainfluenza virus. They end up in the hospital. 17% end up in the ICU. 3% required intubation. Overall, the parainfluenza viral hospitalization rates were highest in the youngest kids, so age 0 to 5 months. So they really conclude, and I think it's important, that PIV infection was associated with a substantial number of acute respiratory infection hospitalizations in children. And if we were not doing the testing, we would not know.
And we will jump into our bacterial section. Be sure to listen to This Week in Microbiology. The first paper I had bookmarked was from OFID, Epidemiology and Outcomes of Bloodstream Infections in Patients in a Burns Intensive Care Unit, an 8-year retrospective study. So, as you can tell from the title, retrospective study. So this was in French burn ICU over 8 years, where about 1,400 people were admitted, mostly with thermal burns. The median total body surface area burned was 10%. They found that 22% of patients had an episode of a bloodstream infection. There was a median of about 2 episodes per patient. These patients were often older and had kind of higher severity and larger total body surface area burned and more complications. So patients who, again, were a little bit sicker on admission, maybe they were on the ventilator. They found that enteral nutrition, especially TPN, was a big factor when they looked at risk factors and things like AKI. All those were associated with development of bloodstream infection. So Pseudomonas was the most common species isolated, which I think is something that we sort of pick up along the way and have heard. So that was the most common pathogen. I think it is interesting. They did see a little bit of sort of a shift over time towards the gram-negative bugs, meaning more of the Staph aureus that's popping up in that first week or so after they come in, then sort of shifting more towards those gram-negatives later beyond that sort of 7 or 8 days. So I think kind of reflecting what we think of this evolving flora as these patients transition, have lost the skin barrier, but now are hanging out in the ICU and getting their care. And they do have some information in there about how many of the gram-negative isolates had resistance. It was a little bit under a third, 31%. But I think this is quite interesting. Obviously, not everyone's center is going to have a burn ICU, a sort of dedicated one, but you may encounter these patients throughout, your care. But I thought this was nice and at least reaffirmed to me that I always thought of Pseudomonas comes to mind when I think of this sort of clinical scenario, and this is confirmation of that.
All right. The article Prophylactic Vancomycin and the Primary Prevention of Clostridium difficile in Allogeneic Stem Cell Transplant, published in Transplant Infectious Disease. So, retrospective cohort study conducted where they compared the rates of C. diff following transplant in folks that got oral vancomycin versus none. Primary outcome was the development of C. diff infection within the first 100 days following transplant, defined as a positive stool toxin assay or PCR. Among the 202 patients, 1 case of C. diff occurred in the prophylaxis group compared to 31 cases in the unexposed group. I don't even think you need a statistician to look at 1.4% versus 23.6% and figure out that it looked like it was significantly less likely to develop C. diff infection during the study period if you got the prophylaxis. But we got some p-values, p-value of 0.003.
Interesting. So I wonder, I guess they were offering it to everyone. I'll have to look back at this. Because I feel like this question comes up a lot on whether or not to give the C. diff prophylaxis.
Yeah, it was pretty compelling here. We're talking about a 95% reduction. I've getting C. diff, for this 100 post-transplant. So, and they got a really nice graphical abstract. So, if you got colleagues who don't like to read, you show them that.
Or no, we had to tell them to listen.
Yeah, they could listen. Yeah, they could
just
listen. You don't have
listen
to
to
look.
us.
Just listen. And yeah, no prophylaxis, 24%, a big red C. diff infection. And you get oral prophylaxis, and it's like this little sliver. It's like less than 2%.
Well, I pulled a lot of bacterial papers today. This one I thought was super interesting. It's from the New England Journal of Medicine, Incidence of Scrub Typhus in Rural South India. This was a population-based cohort study to look at the epidemiologic and clinical characteristics of scrub typhus in about 37 villages in India where the disease is endemic. So as a refresher for those who I guess are maybe thinking about boards in the near future, scrub typhus is an acute febrile infection endemic in parts of South Asia, East Asia, Southeast Asia, caused by an intracellular bacteria. The most dominant in Asia is Orentia tsutsugamushi. So the organisms are transmitted by bite of chiggers or trombiculid mite larvae. But it's known for leaving this characteristic eschar at the inoculation site. So in this study, they went and visited all residents in these 30-ish villages every 6 to 8 weeks over 2 years and drew blood if anyone had a fever since their last visit. They also would try to obtain an asymptomatic control blood draw from someone in the same or neighboring household if possible. And so the villages were selected or included if their seroprevalence of IgG against Orentia tsutsugamushi was at least 15%. This is based on some earlier studies, or those villages that had at least 2 patients who had micro-confirmed scrub typhus recently. I think that was maybe 9 or so of the villages. I'd have to look back. But in over 32,000 participants, so many, from over 7,600 households, they observed 6,175 episodes of fever. A blood sample was obtained in 4,474 episodes, so 72.5%. Of those, 7.3% met clinical case definitions for scrub typhus. So detecting the IgM against the bug on ELISA or having a positive PCR. And so they found an estimated incidence of infection in this highly endemic area of 6 cases per 1,000 person years. And all of this data helped them construct this severity pyramids. You can see the spectrum of severity of the clinical disease in figure 4. So most diseases, that really long orange bar at the bottom, caused no or minimal symptoms. But those who did have symptomatic illness often had severe disease. 71 clinical cases, or 21.6%, required hospitalization. Interestingly, this paper overlapped with COVID. So a lot of the admissions, they estimated about half for febrile illnesses were often in the setting of COVID. But they sort of point out that scrub typhus probably was the next most common cause of fever after that. 29 or 8.8% of the cases were severe or complicated. They also found that high baseline IgG levels did not protect against clinical infection, but instead seemed to confer a predisposition to it. So the authors sort of presume that this is because higher antibody levels mean that they are having more frequent exposure to the vector. But I just think, like, what an incredible, huge study. That seems like so much work. Visiting all these residents over 2 years straight with, they wrote, sort of rare loss to follow up. And it coincided with the first 3 waves of COVID in India. So that, of course, points to a limitation, right? That they were looking at febrile illness in the midst of COVID. And there's probably some contributions too for sort of underreporting fevers and illnesses because of logistical challenges of the pandemic or, the emissions that were driven by COVID. But regardless, like, what an incredible amount of work. That's all that was going through my mind as I was reading the paper. Obviously, super interesting to see, most patients are probably asymptomatic, but of those that are having clinical disease, a lot of them are going to require hospitalization, or at least a good chunk of them. So very cool. Hopefully people have checked this one out.
I'm just thinking, what a treasure trove if, however they wrote this, if they left it open for, hey, now we've got all these samples and only like a certain percent of the time was it scrub typhus. What was it? What was it all the other times?
Yeah, super cool.
All right. The article, Antibiotic Treatment for 7 versus 14 Days in Patients with Bloodstream Infections, published in NEJM. I see you nodding because this is the BALANCE trial. Bacteremia.
I can't remember if we talked about this before. When I saw, because people have been releasing the visual abstracts, I was like, did we talk about that? I don't remember.
Well, our people can email, let us know. But hey, this is the BALANCE trial. What does BALANCE stand for? Bacteremia, antibiotic length actually needed for clinical effectiveness. That was so clever. Do you think they sit around and they like shop this stuff? Like it just
it's got to be one person's job, right? Like,
yeah.
You make this acronym clever.
Yeah. So people remember like, oh, that's the BALANCE trial. Because people are going to remember that. Oh, but what's 7 versus 14? If you look at the data in the BALANCE trial, published in the NEJM, like, wow, this is like going to be like that thing you bring up on rounds. So these are the results of a multi-center non-inferiority trial with a really cool name, where hospitalized patients, included patients in the ICU with bloodstream infection, randomly assigned to receive antibiotic treatment for 7 or 14 days. Across 74 hospitals in 7 countries, 3,608 patients underwent randomization, included in the intention to treat analysis. 1,814 were assigned to 7 days, 1,794 to 14 days. Bacteremia most commonly originated from the urinary tract, 42%, abdomen, about 19%, lung, 13%, vascular catheters, 6.3%, skin, soft tissue, 5%. By 90 days, 261 patients received antibiotics for 7 days had died, and 16.6 receiving antibiotics for 14 days had died. So non-inferiority of the shorter treatment duration. But let's actually look at the percentage, right? So the 14-day group, we've got 16.1% died. The 7-day group, 14.5%. So we have this difference of negative 1.6 percentage points as far as people that died. But we do have this overlapping confidence interval. So certainly did not show inferiority to shorter treatment duration. And, I'm not going to say it was trending in the direction to suggest that shorter was better, but it was. It was.
I'm not going to say it, but I'm going to say it.
But I am thinking that, haven't I? So, yeah, it's really interesting. Less is more. We're like learning more and more of this. I joke on rounds, because there's a lot of, the older attendings who are just really, a lot of opprobrium, a lot of confidence. And I remember training and being, pneumonia, how long do you treat? And the right answer was 21 days. And the patient would like stop early. And then, you'd berate them like, what were you doing? You're going to get drug resistance. You got to treat for 21 days. What are you doing stopping at 7? And now we have like we got to call them up and be like, I'm so sorry. I was wrong. I treated you too long. You should have stopped at 7 days. You were right. Yeah, we don't do that. We don't do that.
Wow, I have dominated the rest of this section, so everyone can buckle up. So the first thing I have is from the Journal of the American Heart Association, Blood Culture Negative Endocarditis, a scientific statement from the American Heart Association, endorsed by the International Society for Cardiovascular Infectious Diseases. This is a nice statement. It actually has a lot of built-in clinical scenarios, which I don't feel like we necessarily have in these types of papers often. And they have some, of course, lovely figures. And they distill this blood culture negative endocarditis into sort of 2 buckets. The first being patients who just got antibiotics before obtaining the blood cultures, so still likely caused by our typical endocarditis bugs, but we have cleared or sterilized their cultures before because of antibiotics. And then there's all the pathogens and the other bucket that don't grow in our routine blood cultures. So kind of other bacteria that will point to a couple mycobacterial fungi. So I like table 1. It's a really nice reference. It has some of the common fastidious causes. So that second bucket we talked about, bugs like Coxiella and Bartonella, mycobacteria, and so on. They do have a diagnostic algorithm in figure 2, which everyone can check out. The one thing I wanted to point out is that they actually do have a specific box right at the top suggesting that if you have the ability to send plasma off, to either hold it or get metagenomic sequencing if you can. The text portion gives a little bit more context and talks about the drawbacks, but I think I do think of this as a scenario where if I have the opportunity to send off a test like a Carius, it can be useful. Obviously, that is based on your institution and if it is doable to get approval and so on. But otherwise, if you kind of walk through the algorithm, I think most of this stuff would be familiar, getting multiple sets of blood cultures, giving blood cultures about 72 hours before sending off some of that extended testing. I think maybe what I'll focus on is they have their empiric antibiotic regimens in figure 3. They have a column for the US recommendations and the European regimens. Kind of generally for the US, they have vancomycin for native valve, culture negative endocarditis. And then they list vanc, rifampin, gent, and cefepime. Hold on, let me make sure. I believe it was cefepime. For early prosthetic valve, and then vanc ceftriaxone if late. And in the comments, I think just to pull out, there does seem like there were some contrasting opinions on whether or not to add rifampin. Some mentioning to add it, once you have source control, some that may suggest using it in late prosthetic valve endocarditis. And then even though gent is in the box of the recommended regimen, the sort of footnote says something to the nature of the writing group is sort of more against it than it suggests. So there's not that much additional info in the sort of body of the text on that. But ultimately, these are all recommendations that are mostly based on expert opinion, clinical practice. So I suspect even with this guidance, there's going to be some variability, but I'll just point this out so that people can refer to this the next time they have a culture negative endocarditis case. And then also on the theme of cardiac infections, I pulled a paper from Emerging Infectious Diseases, Brucella suis infection and cardiac implantable device of man exposed to feral swine meat, Florida, USA. So this is a man in his 70s in Florida who was found to have an ICD infection due to Brucella, but after several admissions, several antibiotic courses for culture negative infection, it even comments, I think, that he had a couple months of suppressive therapy, was ultimately diagnosed. They eventually got the device and pocket fluid sent off through the Florida Department of Health and the CDC for molecular testing. Also eventually had a Brucella serology that was sent in positive. So in retrospect, when they got additional information, it sounds like he had some handling of raw meat and blood after getting some feral swine given to him as a gift from a local hunter. So for learning points, in the US, feral swine, I learned that sus scrofa, aka wild boar or hogs. I Googled to make sure I was thinking of the correct animal. These are the principal reservoir for Brucella. Apparently there are a lot of these, or relatively more of these hogs that were in Florida, which is where this patient was. Something else that was interesting, the Vitek, for this case, when he did have some blood cultures that eventually were positive, it misidentified the organism as Acrobactrum species, which I guess apparently is similar enough that sometimes the Vitek confuses it. So I guess if you see that and the picture doesn't quite fit, maybe think about Brucella. And then the treatment course is oral doxy and rifampin for 6 weeks, or at least that's the current CDC recommendations. So be careful with your swine meat, I guess I should say, and ask about this if your patients are hunters. All right. And then the last one that I have is from Hepatology Communications. Hyperbilirubinemia at hospitalization predicts nosocomial infection and decompensated cirrhosis. Data from the ATTIRE trial. And I'm going to be honest, I did not immediately off the top of my head know what the ATTIRE trial was, so I went and looked it up. ATTIRE stands for Albumin to Prevent Infection and Chronic Liver Failure. It was published in the New England Journal in 2021 and found that in patients hospitalized with decompensated cirrhosis, albumin infusions trying to target 30 grams per liter or more was not beneficial compared to standard of care for primary endpoints like new infection, kidney dysfunction, or death. So that's kind of reflected in guidelines from the AASLD, American Society for Study of Liver Disease, and the American Gastro Association that actually recommend against this sort of routine use of targeting a specific serum albumin level in hospitalized patients. So with that background, this was a follow-up study. They looked at baseline clinical characteristics, and the authors noticed that a ton of the patients in that study got prophylactic antibiotics and didn't necessarily have infections, and that maybe there is a way that we could do a more tailored approach. So they went back and looked at those clinical characteristics to think about can we find something to predict who's going to get an infection. They found the only clinical characteristic at hospitalization that predicted nosocomial infection in univariate and multivariate analysis were elevated serum bili. There was a threshold of over 188 micromoles per liter, yielded a specificity of 80% to predict subsequent infection. So 84 out of 360 patients, or 23%, had a bili above that number at baseline. And those who did ultimately develop this nosocomial infection had a 3 times higher 28-day mortality, 22% versus 6.3%. So the authors kind of said, sensitivity was low. Our aim was to rule in a pre-selected population at risk who would have infection. And so these were patients who at hospitalization didn't have that diagnosis. They weren't treated with antibiotics. So if you look at the infections that they identified, the most common site, 29%, were respiratory tract infections that were diagnosed. Only one had a specific bacterial etiology, so these could have been viral infections. After that, it was UTIs, 14%, and then skin soft tissue, 8%, SBP, 8%. And the median time from trial entry to the nosocomial infection was 6 days. So the author suggests that maybe prophylactic antibiotics in patients with decompensated cirrhosis with these high baseline bili, maybe the people who would benefit. But it's a little bit challenging if the diagnosis was lower respiratory tract infection that could have been caused by viruses that don't actually need antibiotics. So I actually hope that people maybe look at this and think, oh, maybe we should be just more cautious in general about who we should give antibiotics to, rather than jumping to necessarily, oh, someone's bili is X, we're going to put them on prophylaxis. But ultimately, I think that might still be a useful clinical pearl, that if that patient does have a quite high bili that is unexpected or new, that maybe they would be the ones who get infection. But I don't know that there's something specific that I would change in my personal practice at the moment, but I think also because I don't see patients right when they hit the door as a consultant sometimes. But anyways, Daniel,
I'm not
thoughts?
sure what to do with this study, Sarah.
Yeah.
It's interesting, right? It's so it sounds like they're getting a ton of antibiotics to begin with. So initially they're thinking maybe they're trying to rein this in. And then you look closely, like these are sick folks, right? I mean, the 180-day mortality is like in the 30-40 range, right? So these are sick folks. And actually the ones that get the lower respiratory tract, they do better. Have a lower, I kind of am looking at, lower respiratory, UTI, SBP, skin soft tissue. I guess my takeaway would be pay close attention. These are sick people. They have a high 30, 90, 180-day mortality. they have a high risk of getting nosocomial infection. If they get it, you want to like make the diagnosis and then treat. I worry about having them on prophylaxis and selecting for like MDR, right? Multi-drug resistant infections. And so.
Yeah. And it's hard because I don't think there is going to be, well, maybe future ID doctors can fix it. But like, I don't know that there's going to be a specific lab test when someone walks in that is going to perfectly predict who's going to have infection. Obviously, it'd be nice if it was more tailored, but so much of it depends on their clinical picture that I think it's hard to rely on a data point like that. It's always still about that sort of trend and how they're doing.
Fungal. We're in fungal, Sarah. Last of Us season 2 is coming in April. When in April?
A couple weeks.
When in April?
I think it must be right after White Lotus ends. I'm assuming there's 2 more. It's 2 more episodes of that.
Okay, well, Last of Us season 2 is coming in April. We'll let you know. The article "Fungal Infections in People Who Use Drugs" was published in OFID, Open Forum Infectious Disease. We read that surveillance studies report that 28 to 34% of candidemia cases are linked to intravenous drug use, with Candida albicans being the most commonly isolated species, followed by Candida parapsilosis and Candida glabrata. Marijuana use is associated with lung infections caused by Aspergillus and the Mucorales, showing a 3.5-fold increased risk of mold infections and a 2.2-fold increased risk for other fungal infections. Intravenous drug use also presents a recognized risk factor for Aspergillus and Mucorales infections. And I thought this was really something just to kind of put on your radar, folks. Listen, this is important. Takeaway message. Substances like cannabis, methamphetamines, and opioids share metabolic pathways with triazoles, a class of antifungal, and terbinafine through the CYP enzyme system. So these antifungal drugs strongly inhibit CYP3A4 and CYP2D6, leading to potential drug interactions, adverse events, overdose risks, and even death. So I don't know how you do this. You tell your patient who's got a drug issue, I'm going to put you on a triazole. By the way, this might make your drugs more potent and so much more potent that you might die. So you might want to cut back. I don't know. I'm trying to figure out how to put this into practice, Sarah. You let me know.
Yeah.
All right. IDSA 2025 guideline update on the treatment of asymptomatic histoplasma pulmonary nodules and mild or moderate acute pulmonary histoplasmosis in adults, children, and pregnant people. Are they allowed to say that in 2025? Published by IDSA 3/12/2025. In adults and children with asymptomatic non-calcified pulmonary nodules related to histoplasmosis with no evidence of other active sites, or asymptomatic patients with known untreated prior infection, the panel suggests against routinely providing treatment. But then they say it's conditional, very low evidence, certainty of evidence. And then we get some more advice in immunocompetent adults and children presenting with mild acute pulmonary histoplasmosis. Again, against treating these folks in immunocompetent adults and children with moderate acute. The panel suggests either give an antifungal treatment or not. And then in immunocompromised folks, yes, if they have moderate to high risk of progression, you want to treat them. So there's a lot of keep your hands in your pockets and only treat in certain contexts. Mm-hmm. All right, Candida auris, the article Changing Trends in the Sources and Volumes of Clinical Cultures with Candida auris at a Large Health System, 2019 to 2023, was published in AJIC. This was so good, I almost put it in twice, but yeah, don't need to do that. So a couple highlights, 5 highlights. So in this study, they characterized these sources and volumes of clinical cultures with Candida auris. Blood cultures are the most common specimen. The proportion of blood cultures from total of cultures has recently decreased. Bone and soft tissue specimens has the largest percentage of increase. And the volumes of clinical cultures increased every year and the infection sources expanded. So you can imagine this made it into some of the, I don't know if it's the popular, or shall we call it the unpopular press that I read. Here they conducted a retrospective observational study at an integrated health system. They included clinical cultures with C. auris collected from April 1, 2019 through December 31, 2023. They identified 327 clinical cultures belonging to 231 unique patients, and the number of clinical cultures increased each year from 5 in 2019 to 29 in 2020, 71 in 2021, 107 in 2022, and 115 in 2023. So all sequencing isolates belong to clade 3, which is a South African clade, and were resistant to fluconazole and susceptible to echinocandins and to amphotericin B. So we need to find out who is that South African who is spreading Candida auris throughout our country. I can think of one South African troublemaker that comes to mind. All right. Another article, the diagnostic test accuracy of the Fungitel serum 1,3 beta D glucan assay for the diagnosis of Pneumocystis jirovecii pneumonia, a systemic review and meta-analysis published in CMI. I'm going to turn you into a believer in Fungitel before long, Sarah. Trust me. So for background, they start with the diagnosis of Pneumocystis jirovecii pneumonia can be challenging because of diagnostic tests that are imperfect and or invasive. The Fungitel assay is a non-invasive blood test studied for PCP. However, the manufacturer recommended cutoff of 80 PGs per ml is not well validated for this disease. They conducted this systematic review and meta-analysis, and they found that the pre-test probability of less than 20% and a BDG of less than 80, the post-test probability would be less than 5%. So if you're not thinking it's Pneumocystis jirovecii pneumonia and you got a BDG of less than 80, it probably is not. But if you think it might be, and you've got a 400 PG per ml, then your specificity is going to increase to 93.6. So at a pretest probability of 47.5, so 50-50 it might be, a BDG of greater than 400, then your potest probability goes up to greater than 90%. So they're suggesting a categorical approach using a less than 80 to rule out and a greater than 400 to rule in, suggesting this might allow a more nuanced interpretation that Sarah might like. Okay. All right. Parasitic. Be sure to listen to This Week in Parasitism. We have, let's see how many. We've got like a few good ones. And you jumped in here too. So Sarah's going to be back in a moment. So the article, Impact of Strongyloides stercoralis Co-infection on Disease Severity and Treatment Outcomes in Pulmonary Tuberculosis, was published in Open Forum Infectious Disease. They looked at patients from Chennai, South India, enrolled in the prospective effect of diabetes on tuberculosis severity. They found that the pulmonary tuberculosis patients co-infected with Strongyloides stercoralis had significant higher bacterial loads, increased risk of bilateral lung lesions, greater likelihood of cavitary disease. The co-infected individuals had significantly elevated levels of a number of cytokines, profibrotic factors, fibroblast growth factor, and significantly diminished levels of the cytokines interferon gamma and IL-2. We've got a nice figure that I put in there with the particularly interested in all the fibrotic factors that we're seeing there.
Yeah, I'm making a rare appearance in the parasitic section with a paper from Parasitology. Hematology thin smears perform equally to parasitology thick and thin blood smears for the diagnosis of Plasmodium and Babesia infections in a low prevalence setting. So the conclusions are pretty clearly stated in the title, but for a little more detail, the authors retrospectively compared thin smear, so again, from the heme lab versus thick and thin parasitology lab, which is our gold standard. They had 520 cases with paired testing. I'm not going to run through all the pairing. Basically, just to say there were only 4 of those cases that were discordant, and all of the discordant meaning one or the other was positive. All of those were in the setting of follow-up monitoring of a known diagnosis in patients with parasitemia values lower than the level of quantification. So thin smears demonstrated 93% sensitivity, 99.8 specificity, with 98% positive and 99% negative predictive values. And when considering only new diagnoses, so if you ignore those discordant cases with follow-up monitoring, the hematology thin smears and the parasitology thick and thin smears were 100% concordant, with no significant difference found in the percent parasitemia. So the hope would be that if a lab doesn't really have another way to diagnose blood parasite infection, like access to antigen or additional testing, that this would make it seem that hematology thin smears would be a reliable way to diagnose these infections in this low prevalence setting. I believe it was in Wisconsin. It does sound like, they trained a general technologist and the heme lab that was doing the thin smears on how to recognize Plasmodium babesia, but not to differentiate further. So you do still need to have someone who has some additional specialized training, but it still would be a big difference between having to have someone doing the thick and thin and follow up. So I thought that was pretty cool.
All right. Well, we are getting near the end, folks. Hang in there or take a break and come back. But the MMWR, this is fun. Notes from the field. Rhodesiense, human African trypanosomiasis, sleeping sickness in a traveler returning from Zimbabwe. United States, August 2024. So August 2024, CDC was contacted regarding a U.S. traveler aged 57, recently returned from safari in the Zambezi Valley in northern Zimbabwe. Patient was evaluated at a U.S. hospital with a 2-day history of fever and a well-demarcated ulcerated lesion on the left thigh, approximately 2 weeks after being in Africa. No neurological symptoms. A peripheral blood smear obtained to rule out malaria revealed parasites in the blood consistent with Trypanosoma brucei species, and then confirmed by the CDC. So good so far, right? In accordance with WHO guidelines, oral fexinidazole was initiated. The patient rapidly progressed to multi-system organ failure, required dialysis, intubation, intramuscular pentamidine, an alternative anti-trypanosomal drug, was added, giving the uncertainty of the fexinidazole absorption by the feeding tube. Ultimately, the patient received 10 days of pentamidine and fexinidazole and was discharged home with only mild renal dysfunction. No signs of relapse were evident 6 months after discharge. All right. And we got a couple here in the miscellaneous. I will start us off, and Sarah, you can go next. But I am thinking that this would make a great gift. This is the article "History of Phage Therapy" was published in the Lancet Infectious Disease, and this is in the Media Watch book section. So they're plugging a book. We read there are all kinds of reasons why the use of bacteriophages has failed to take off in the USA. By the mid-1940s, Western phage treatments were largely discredited, explains Lena Zeldovich in her intriguing history book, The Living Medicine, how a life-saving cure was nearly lost and why it will rescue us when antibiotics fail. Some simply weren't a good match for the infections they were used to treat. Some made false claims promising to cure ailments that weren't caused by bacteria, and others might have been downright fake. So The Living Medicine, how a life-saving cure was nearly lost or why it will rescue us when antibiotics fail, is available as hardcover, Kindle, or audiobook. And I'm started listening to the audiobook. So.
Nice. And I believe I have the last paper. I do. Okay. So I pulled from CID, Silence Equals Death, Redux, Infectious Diseases, Public Health, and the Imperative to Resist. So this is a nice perspective piece from Ilan and Eric, and I'm going to quote here that they've written to implore the ID community to urgently and forcefully defend the people for whom we care, the public health institutions on which we rely, and the principles in which we believe, drawing some comparisons to the LGBTQ plus community activists and early HIV clinicians, and, noting the changes that have been happening with our administration in these past couple, I guess it's weeks, it feels longer. They note that, the silence of some of our medical societies that have been, at least initially, and or still reluctant to make statements in an effort to stay, quote, bipartisan. But I also drew another sentence that I feel like summarizes things quite clearly. The actions of the Trump administration and congressional enablers make clear that their goal is not to improve an imperfect society, but to destroy and fundamentally rebuild one based on contempt for egalitarianism, truth, and justice. Oh, almost.
There they are using those big words, those coastal elites. Look at that.
Guys. So they encourage continuous and forceful advocacy and give some major steps, reaffirming our commitment to inclusion, diversity, access, and equity across all of the efforts that we do, ensuring that our trainees and our colleagues and our patients are protected from harassment, that we are advocating and providing the best care that we can to our patients, defending science and evidence-based medicine, and the scientifically informed policy that should reflect those and impact our patients and communities, to vigorously oppose censorship, including especially our science-based communications. And then just kind of closing out by pointing out that this is a marathon, right? It's a long fight, and to sort of see it as that. And, public health science and our patients are under attack, and our allegiances are being tested. So for those who, I actually can't remember if specifically referenced in the perspective, but I put some links here for some of the old posters and other art pieces and documentaries for Science Equals Death, which was a slogan and sort of rallying cry for AIDS activism. And so there's a couple exhibits. I think most of them are specifically from the New York City community. And so if people wanted to take a look at those, I just tried to grab a couple. But honestly, if you just search it online, you could find lots of either posters or videos or interviews and so on. All right. And so with that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, at microbe.tv/Puscast. Grab it with your favorite podcatcher or watch us on YouTube, and then make sure to subscribe. You got to do the thumbs up. I don't know what that's called. Thumbs up, like, yes. Make sure to subscribe, like us, ring the bell, leave comments. I have been listening to other YouTubers. They say this stuff. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com, and click on the donate button.
I'm Sarah Dong. You can find me at Sarah Wynn Dong or Febrile Podcast on Blue Sky or at febrilepodcast.com.
And I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.